Hi everyone, welcome to the second episode of BreatheTV, where we sit down with clinicians, respiratory therapists, and nurses to discuss the use of high-flow nasal cannula and other respiratory support modalities. Today we have Dr. Mike McQueen with us today, and really happy to sit down and spend some time. It's been a little while since we connected last, so happy to be here in Phoenix, Arizona. And I'd just like to give Mike the floor to introduce himself.
Thank you, Chris. It's good to see you, and thank you for the honor of including me in this. I'm glad you said clinicians, because that's probably the best answer to who I am. For 27 years, I've been a primary practice neonatologist. I've worked in multiple settings. For close to a decade, I was the medical director of our local children's hospital here in Arizona, Phoenix Children's Hospital. Subsequent to that time, I've branched out and done more community hospital work. Currently, the practice that I'm affiliated with is involved in 7 community NICUs here in Phoenix. 2 of those are level 3 nurseries, and 5 are level 2 nurseries. And again, I've been doing this for about 27 years, and I've been using Vapotherm since about 2005, so I'm in my 12th year now of using it.
Awesome. So I think that gives a little interesting perspective, because you've been in practice prior to when high flow was available. And so you can really speak about the progression and you were using CPAP before that, I assume?
I was, and obviously all forms of mechanical ventilation as well. And I can tell you, I think it's relevant to those of us, especially who did or who have practiced for quite a while. 3 things in my career have changed the way that I practice at the bedside. The first was the widespread adoption of prenatal steroids. That's where I think we probably saw the first impact on neonatal outcomes that was markedly noticeable to all of us. Secondly was exogenous surfactant. And I actually am old enough that during my fellowship I was involved in some of the surfactant trials. My fellowship was at the University of Vermont, and it was one of the greatest privileges I've ever had to study and train with the gentleman at that facility. And then the third thing, frankly, has been high-flow nasal cannula, Vapotherm. It's actually changed the way that I've practiced in the last decade.
So Burlington, Vermont, amazing place. Really nice on Lake Champlain. I've been up there a few times and like it. Could you just tell me about that? I think it's interesting talking about the transition from CPAP to high flow and what that meant for your practice. And I guess to give some value to the audience, thinking about what that was from an organizational change standpoint as well.
I was lucky to have a supportive respiratory therapy department and a lucky administration as well. When I started this current practice, that was in 2005, and it was just me. There was one physician, so there wasn't a lot of group consensus to be reached, and I was at one level 2 hospital. That facility has since grown to a level 3 nursery, and again, we've expanded into 6 others, so we have 7 total. But because it was a new program and a startup, I think we had people more willing to try things that were being introduced, and so we really started using Vapotherm in 2005. We stopped using it in 2006, like everybody did when it was briefly pulled off the market, and obviously all that sole issue was resolved, and then resumed using it again in 2007. That gap is relevant because that really emphasized to us how much we missed it. Since we used it in all of 2005, couldn't use it in 2006, the nurses bugged me every day. When do we get Vapotherm back? And the CPAP is harder to use. The babies don't like it. The families don't like it. We don't like it. It's just harder to use. Mm-hmm. Still clinically effective, obviously, but just more cumbersome. And so when Vapotherm came back on the market in 2007, it was not hard for us to switch, and we've used it extensively since then.
And so I assume, but correct me if I'm wrong, everything started mostly as using high flow as post-extubation support, right? Or
It did, because that's, what we had heard, and that was kind of the standard wisdom. We felt so comfortable with it within a few months' time even, that we said, look, especially on babies maybe that were a little older, 32 weeks and beyond, and whose respiratory distress maybe wasn't that severe, we would say maybe they don't need intubated in the first place. And we were thrilled because we started having significant success at keeping those babies off the vent altogether. As we got more comfortable and a little more aggressive, we started using the insure method. We would intubate, give a dose of surfactant, extubate directly to high flow nasal cannula. And probably from 28 weeks and above, it was rare for us to use the ventilator anymore.
And that's amazing, right? Because the real goal with infants in respiratory distress is to prevent prolonged mechanical ventilation because of all the associated morbidities with it, correct?
It absolutely is. You know, with all due respect to the really well done and well designed trials that have used intubation and surfactant administration as a marker for treatment failure. I think for the purpose of that study, obviously it was. They can define it however they want. From a, again, clinician pragmatic standpoint at the bedside, treatment failure is when the baby ends up intubated for weeks on end or even days on end. So we don't consider giving surfactant a bad endpoint, and if it keeps the baby from being intubated, it's just a good adjunct.
Sure. And so let's hone in right now on post-extubation support. Earlier in 2016, the Cochrane review was published for analyzing high-flow nasal cannula in comparison to CPAP for post-extubation support. And could you just walk me through what conclusions you draw from that paper?
Yeah, I think it actually looked at a fair number of studies, 15 or so, comparing high-flow nasal cannula with just other non-invasive means of respiratory support. And I think there were two significant takeaways. One is that there was really no clinical difference between the two, so it sort of validated the efficacy of high-flow nasal cannula. Secondary outcomes have always kind of reared their head. And I think the Cochrane even supported that. There was less nasal trauma with the high-flow nasal cannula and even a trend towards less pneumothoraces.
Mm-hmm. And so nasal trauma, I mean, that's really one of the big drivers to adopting high-flow. I think besides the clinical efficacy, using high-flow has been shown in all the randomized control trials, as far as I know, to significantly reduce nasal trauma. And could you just speak to that in your experience in your practice?
It's absolutely true. And again, just from both comments that you made. As far as I know as well, Chris, in all of the trials, when the secondary outcome measures do include nasal trauma, the high-flow nasal cannula has been superior to the CPAP device. Clinically, using this now in several thousands of babies over the last 12 years, again in level 2 and level 3 settings, we've absolutely seen that. Mm-hmm. The ease of use, I think, is probably a corollary to that. It's just comfortable. The babies don't fight it. The moms can do kangaroo care. We've had 26, 27, 28 weekers doing kangaroo care on high-flow nasal cannula. It's really been, it's one of the things that's changed the way we practice medicine. Vapotherm is so much easier to use than CPAP that I think there's kind of a snowball effect. The babies are more comfortable. The nurses are more comfortable. It makes the families more comfortable. Mm-hmm. There is kind of a momentum built up. Certainly when it's introduced into our nursery, we were like everybody, you know, is this going to work, and do we know how to use it, and are we doing the right thing? And the first time we extubated, I think even a 28-weeker, after giving surf, we all looked at each other and said, are we sure? And obviously nobody left the bedside, but as our confidence grew, our unit is so bought into it that it's just a given. I mm-hmm. can't tell you the last time we've actually used CPAP. It's a tool that we still do utilize, but in our level 2 nurseries, hardly ever. It's almost all high-flow nasal cannula. It's Vapotherm virtually exclusively. And even in the level 3 nurseries, we use RAM cannula, we use the oscillator, we use conventional ventilation. I mean, we use all the tools, but it's amazing how our ventilator days have decreased and how our CPAP use has decreased.
Mm-hmm. And so I think a lot of people see, and you were kind of ahead of the curve, the momentum that's building and the randomized controlled trials that have been published most recently, the 2016 trials. And the way that I saw it, it kind of started, in the 2013 timeframe where you look at post-extubation support and then kind of moved, okay, now that we can get kids off the vent and support them that way, now let's look at preventing intubations. And so there was 2 major trials published in 2016, one by Anna Lavazari out of Italy and Fabio Mosca's group, as well as the Hipster trial out of Australia and the UK, I believe. So just kind of talk me through the differences in those trials and what that's meant for your practice.
Yeah, that's a good observation, because the progression of the clinical trials that have come out has really mirrored what we saw in our 12 years of experience thus far, and that is starting with post-extubation support and progressing to perhaps we can keep the babies off the ventilator and extubate it all together. The Hipster trial, actually, I've received a lot of correspondence on the Hipster trial, because the initial takeaway was, oh my gosh, CPAP is so much better than high-flow nasal cannula. I had the utmost respect for that, those researchers, and the trial was incredibly well done. A couple of comments. Of the 278 babies in that trial that were randomized to high-flow nasal cannula, about 2% of them, 6 babies, were on Vapotherm. So I think that caught my eye for one thing. If there is a difference between devices, that would come into play, but that's certainly a worthwhile observation. And secondly, that was one of the trials that decided to make surfactant administration an endpoint in defining treatment failure. And so while I respect that, and that's obviously great for a trial design if that's how they wanted to look at the outcomes, what I really took away from that was for stiff, non-compliant, surfactant deficient lungs, CPAP works better than high-flow nasal cannula. And I thought, yes, it does. I didn't think it was a stretch to find that at all. And I think if your goal is to try to not administer surfactant, CPAP probably does increase your odds. Of note, if you look closely at that trial, there was kind of a rescue branch. If the babies failed high-flow nasal cannula, they were switched over to CPAP, and the likelihood of being intubated either just from CPAP or high-flow nasal cannula and then switched to CPAP was virtually identical. There really was no statistical difference in that. Given the nasal trauma discussion that we just had, you should really argue, if you read it closely, you should still start with high-flow nasal cannula, switch to the CPAP if the patient meets your failure criteria, and then proceed either to the surfactant or more aggressive support as needed. In my clinical opinion, again, I think you can actually use the surfactant, not willy-nilly. We don't give it prophylactically in the delivery room anymore. There was a time when we all did that. But if the FiO2 starts to hit 30, 35, 40%, that's the criteria that most people use clinically and in the studies that have been done. If the baby has air bronchograms, if he's working hard to breathe, if you think he has RDS and is surfactant deficient, treat him with surfactant. And you won't need to have him on the ventilator, and chances are good you won't need to switch him over to CPAP either.
Okay. And so we talked about the hipster trial and only 6 patients being treated on Vapotherm in that trial. And let's switch gears now to the trial that was done out of Italy, published in JAMA Pediatrics by Anna Lavezzari and colleagues, that used exclusively Vapotherm in that trial. And let's just kind of try to hone in on the differences and then the conclusions that you draw from that one.
Yeah, Dr. Lavezzari's trial showed again that there was no difference between high-flow nasal cannula, again, you're right, Vapotherm exclusively, or CPAP, either CPAP or BiPAP was the control group. I liked a couple of things about that. The fact that she took the plunge and said, yeah, let's test this for primary support for RDS, because again, I think that's what we're evolving to. Secondly, she used surfactant. She set a criteria, it was either 35 or 40% FiO2, but if the babies met criteria for surfactant, whichever arm they were randomized to, they got the surfactant. And again, she found no difference between the two modes of respiratory support. There was, I think she could have even been more aggressive in that trial because she limited her high flow parameters to 6 liters per minute. And we know in the infants that Vapotherm is approved to go as high as 8 liters. And given the insufflation mechanism of action of Vapotherm, I think she even shortchanged herself a little bit by not maximizing that. But still no difference. And again, the secondary measures showed less nasal trauma and less pneumothoraces. And
it's interesting you mentioned that, because I had actually been able to have a conversation with her just a few months ago. And I always asked researchers about their trials, what's one thing that you would change if you could go back and do it all over again? And she had said that she would have gone up to 8 liters and seen how that went. And I think that's a nice segue into some of the work that Dr. Yoder's been doing, that you've been a part of, in looking at trying to find consensus on how to administer high flow. And so I'd love if you could talk us through a little bit about that.
Yeah, thank you for sharing that. I didn't know Dr. Lavezzari felt that, and I'm glad she made that observation and reached that conclusion, because again, up to 8 liters is approved and safe. So Dr. Yoder has been doing some incredible work, like he always does, and among other things, he presented at Hot Topics just this past year, and there will be a paper shortly submitted for coming out in publication on consensus use of high-flow nasal cannula. He had 7 different investigators from across the globe. I was privileged to be one of the clinicians that got to be surveyed in the Delphi method questionnaire that he used to define consensus. virtually not virtually, all of the investigators did agree that up to 8 liters was the maximum in the babies. Nobody uses more than that. I've heard anecdotally some reports of colleagues who are trying to exceed 8 liters. It's not approved for that, and I think we need to be careful, but
Sure.
up to 8 liters certainly seems to be the consensus among a wide spectrum of investigators.
Excellent. And so I suppose in that paper they'd reached pretty uniform consensus on using it as post-extubation support. Meanwhile, I'm not sure that we've fully drawn conclusions on how to administer it as primary support. So, I mean, I think maybe instead of diving into detail on that, it would just be interesting to talk about how you use it in practice in both primary support and post-extubation support. If there's differences in flow or anything, that would just be interesting for the audience.
Yeah, you're right. You remembered his presentation well if you were there, because that was exactly right. There was strong consensus to use it for post-extubation support, and there was a slight majority that high-flow nasal cannula could be used for primary respiratory support, but it was not the same degree of consensus as the post-extubation. Again, just speaking for our clinical experience, we use it very aggressively for primary support right now. And to repeat again, babies 28 weeks and above, unless they have decreased respiratory drive for some reason, a hypoxic event, perhaps mom was severely hypertensive and the baby's born with hypermagnesemia and respiratory depression from that. Assuming a normal respiratory drive, just run-of-the-mill, so to speak, prematurity and RDS, 28 weeks and above, we have incredible success at never having those babies on the ventilator. Probably 20 to 30% of them do get a dose of surfactant. Again, not 100% at all, and probably not even half. Below that, it's kind of a sliding scale. We've had 26-week babies that have had 0 ventilator days, which is amazing. It is. It's changed the way we've practiced. That's not commonplace. I don't want to give the impression that, oh gosh, for 26-weekers, we don't use the ventilator. Not true at all. But for maybe 10 to 20% of those 26-week babies, we think there's again, just clinical experience. We think there's almost a profile. If mom doesn't have choreo, you're not worried about the baby being septic. Mom had prenatal steroids. The baby doesn't have any respiratory depression. You know, kind of a primed candidate, as it were. But with that, and again with the administration of surfactant, not prophylactically, but aggressively, if we're convinced that the baby is surfactant deficient and starting to show increased FiO2, we don't let them tire out and work hard for hours on end until they hit 40%. If they have air bronchograms, they're working hard and they're that early gestation, we treat them, we extubate them to high flow. Sometimes we have to escalate to CPAP or to ram cannula or to even intubation. That it absolutely still happens, and all those tools are fair game. Getting the nursing staff, the respiratory therapists, your physician colleagues bought into making the effort and the method, we've just had incredible results.
Awesome. So, and one piece in the hot topics that I found really interesting was just the importance, the criticality of using and properly targeting oxygen saturation levels. So I was wondering if you could just talk me through that in practice, day to day, what your target saturations are and how you manage that.
You know, I think it's probably fairly typical. No one still, I think, has reached complete consensus on what are the right O2 saturations. But I would wager that we're within you know, the standard deviation of what is a national practice. Between 88 and 93% is kind of a typical target for us. And so if we start to hit, again, FiO2s of 30, 35, we start thinking surfactant pretty hard. And at 40%, I'd say it's pretty rare for us not to.
Okay.
There obviously, like any practice, there's practitioner variation even within our own group. Some folks will wait a little bit longer. Work of breathing, you know, part of it isn't just the FiO2. We're standing there looking at the baby, and if there's significant work of breathing and retractions and poor air movement, again, we think we can help. We don't have to let a checkbox be reached before we intervene on that patient if we're standing there looking at him with our own eyes.
Definitely. And so, correct me if I'm wrong, but I believe you mentioned 2 level 2 NICUs in the greater Phoenix area, as well as 2 level 3s.
Yeah.
And 5 level 2s. And so I kind of want to focus in on the level 2 NICUs, because I think there's a great opportunity for them to start using high flow nasal cannula and then reduce possible transportations and then escalation to mechanical ventilation, increase family satisfaction to not have to move to a different hospital, and just want to see if that holds water in your experience.
I have nothing to add. It's exactly the right question. One of the biggest, certainly all the things we've been talking about for level 3 utilization hold true. For level 2 nurseries, this absolutely can be a game changer in program development and in census maternal satisfaction. We have, I can give you one example and show you some data on this. This is a level 2 nursery in the periphery of the greater Phoenix metropolitan area, where we started providing the high flow nasal therapy model in September of 2010. You can see that in the years prior to our starting, this is a facility that has about 1,700 deliveries a year, so it's not huge. But even with just 1,700 deliveries a year, prior to the introduction of the aggressive use of high flow nasal therapy, 30 to 40 babies a year were transported out of this hospital into a level 3 nursery. This slide shows that since we implemented the model, the number of transports per year has fallen to about 2 or 3 per year.
Wow.
It's a 20-fold reduction in transports. It's unbelievable. This slide, interestingly enough, just because we looked at the number of Vapotherm cases, it basically mirrors the number of transports that used to be sent out. That's why they're staying. Predictably, from a level 2 nursery, a lot of those babies, most of them, were sent for respiratory issues. Not always, and we still transport out some babies. But for routine respiratory support, we do give surfactant in the level 2 nurseries. Of note, we also have in-house 24/7 nurse practitioners in those level 2 nurseries. And so there's good clinical backup for the kids. So that allows us to implement the therapy safely and be more on it. But we again, a 20-fold decrease in transports. That has to catch any administration's eye and any payer's eye in this cost-conscious healthcare evolution that we're all caught in the middle of. Maternal satisfaction, you're exactly right. We're not separating the moms and babies. The OBs are happier. They get to keep moms there and deliver at that community facility instead of sending them out. Level 2 nurseries should be all over Vapotherm, and I know I'm a little biased, but we have the data to back it up.
Excellent. And so a lot of the things you talk about are ease of use, and so in a level 2 NICU that may not have full-time neonatologists on staff, I think that ease of use plays a big role. And so I was wondering if you agree and what you have to comment on that.
It does. You know, as opposed to CPAP, which I would be a little bit reluctant to use if there weren't nurse practitioners in-house 24/7. Again, we use CPAP in the level 2 nurseries too, just rarely anymore. But because of the risk of nasal trauma, because of the risk of pneumothoraces and acute respiratory deterioration, we would prefer not to use it. If we can use Vapotherm instead, we do. And it is so easy to use that while we do employ a 24/7 in-house model with our advanced care providers, it's because we've chosen to do it that way with proper education. I really want to emphasize that. Definitely. With proper education about how the cannula interfaces to the baby, the mechanisms of action. I think a level 2 nursery with immediate response time from their neonatologist could also safely use this as opposed to CPAP.
So I think that was a good segue into a paper that you were a part of that was published in 2013 about the economics associated with high-flow nasal cannula usage in a level 3 NICU. And so I just wanted to open the floor to you about your experience and the part you played in the paper, as well as the conclusions that you've drawn and how it's impacted your practice.
Great. Thank you for noticing that and for asking about it. You're right. It was in the Journal of Health Economics and Outcomes Research in 2013. Dr. Jan Peach was the lead author of that. This was our experience and quantification of ancillary cost savings in a level 3 NICU, our biggest and busiest level 3 NICU. We basically did a before and after, the 6 months before we implemented the high flow therapy and the 6 months after we had implemented Vapotherm in that level 3 NICU. And what we showed was about a 25% decrease in ventilator days. We showed a 50% decrease in chest x-rays, right? The babies weren't intubated, so we didn't need to get a chest x-ray every day and make sure the ET tube was in good position. We showed a 50% decrease in blood gas utilization because a lot of this is clinically monitored. We follow the baby's oxygenation via pulse oximetry, His work of breathing is a good indicator of his ventilation status. If we have any questions, we get an X-ray. If we have any questions, we get a blood gas. But again, a 50% decrease in those ancillary services. So even in the level 3 NICUs, it seems to make an impact. We didn't look at even downstream measures. Because we had fewer blood gases, did we have fewer blood transfusions? Because we had fewer blood transfusions, did we have to hold the feeds less often, and did we get to full feeds faster? We didn't even look at any of that. Just the ancillary support services told us that we were on the right track in being more cost effective with this, even in a less level 3 NICU.
You mentioned the pressure, right? And so a lot of places and doctors sometimes have reluctance to implement high flow, especially at the liter flows that you're talking about, because of, I don't know, the pressure type of concerns. And I think it's interesting when we look at all of the randomized control trials with high flow compared to CPAP, both post-extubation as well as primary support. There's two major differences that I see. One is a significant decrease in nasal trauma.
Yep.
And the second one is there's either equal or at times significantly less incidences of pneumothoraces. And with that, I think it's a reasonable conclusion to draw that you're not generating any dangerous types of pressures. What do you think about that?
I totally agree. And again, applied correctly or not. Look, when we started, we had exactly the same concerns. How much pressure are we generating? And worse, we didn't know. Every mode of mechanical respiratory support is based on pressure. Doesn't matter if it's a conventional ventilator, an oscillator, NIPPV with the RAM cannula, CPAP obviously speaks for itself. It's based on pressure. This is a whole different mechanism of action. That flow is going to generate some pressure, especially during exhalation, but it's about equivalent. Some researchers have shown that to a baby doing pursed lipped breathing during exhalation. And again, with proper application, meaning room for egress of that pressure buildup. Don't occlude the nares, have the mouth open. There's no reason that you should be generating any dangerous levels of pressure. There's no way it should be transmitted to the lungs.
And that's what it's all about, right? At times, if you can, the mouth open is an excellent scenario to have, but it's really about fitting the prongs properly to less than 50% occlusion. And with that, there's plenty of space for gas egress, even with the mouth closed scenario.
Correct. I think the nasal prong is absolutely key. And to illustrate that even further, Vapotherm even has, as you well know, a uniprong cannula to kind of demonstrate that you're not trying to generate pressure, and in fact just the opposite, you're trying to allow room for egress. But certainly the nasal occlusion is the main thing to avoid. But if you can't always keep the baby's mouth open, sometimes they close it. When you're trying to do CPAP and want it closed, sometimes they open it. So it's hard to give that one, but a perfect fit in our world is the nares 50% occluded or less and the baby's mouth open. That we've just had no issues going up to 7 and 8 liters per minute.
Any last comments?
Thank you for letting me participate in this.
It's been great, right? So the idea is that we continue this on a regular basis, and maybe in a year we come back and cover some of the interesting new evidence and just kind of open up the conversation to everyone and try and be an educational resource and a tool that people can go to learn and share experience. So again, you've been a proponent for high flow for a long time, and so we really appreciate you joining us today. It's been good to see you.
I appreciate you again inviting me. I use Vapotherm because I believe in it, and I don't use it because you invited me. So thank you.
Thank you.